So good morning, everybody. Thank you very much, Nagia, for this invitation and this introduction. So I'm adult neurologist, but I do also transition in neuromuscular disorders. So it happens to me to see children and adolescents that become adults. Today we will go through together the main signs and symptoms of the neuromuscular disorder that you need to recognize when you evaluate a child with a suspected condition like this. So just a reminder of the neuromuscular unit that is by the motor neuron, the peripheral nerve, the neuromuscular junction that is very important because here there are localized many proteins that when they are affected they could provoke in children the congenital myasthenic syndrome, but also is the target point of antibodies for the acquired autoimmune myasthenia. And then you have the muscle fibers, where you have the contractile apparatus with the structure that are the sarcomere. Then, when altered because of genetic mutation in condition in proteins that build that are the bricks of this apparatus or in proteins associated with the organelles can provoke the muscular weakness. So in general, when you evaluate this kind of patient, you have to make a localization effort and to determine if the problem is in the motor neuron, in the peripheral nerve, or in the neuromuscular junction, or in the muscle fibers. Of course, it's not an easy task. There are many conditions, multiple gene, multiple syndromes, myopathy, muscular dystrophies, and you need to orientate yourself through this difficult work. But we know that we can already make a big distinction between two groups, the group of genetic condition, genetic myopathies, for example, congenital myasthenic syndrome, and the acquired condition. So, as we are talking of children, you have to understand that the majority of neuromuscular disorder in children are genetic, but there are some acquired myopathies, like, for example, the autoimmune mediated necrotizing myopathy or the dermatomyositis that also happen in children. And then you can have also myasthenia, autoimmune myasthenia in children. But in general, think first genetic, and then you can exclude if there is an acquired disease. What are the general features? As I already said, these conditions are mainly inherited in children. Their prevalence is below 5 in 10,000, which means that are rare disorders. And the clinical manifestation can be very stereotyped with a muscular weakness, fatigability, atrophy, but I will show you videos and picture of the patient so you can recognize the different pattern and the different sign that can orientate you toward a diagnostic flowchart. There is a variable clinical presentation and severity. Some are mild, stable, some are fluctuating, some are very progressive, okay, with the loss, for example, of ambulation, like in Duchenne muscular dystrophy. And in general, although there are exceptions, you don't have a cognitive impairment in this condition, although we now know better that, for example, in Duchenne muscular dystrophy, in 30% of patients, you have either a mental retardation, either a autistic spectrum disorder. And also you can have the congenital muscular dystrophy where there is a prominent involvement of the central nervous system with epilepsy, malformation, and other, for example, organs that are touched like the eyes. And then, of course, the mitochondriopathies that are linked to alteration in the central energy productor of our bodies, the mitochondria, that can manifest with a large spectrum of symptoms and signs. These are disorders that are chronic, they can be variably progressive. So it's very important once you recognize that you follow up this patient, that you propose a therapy if this is available, like for example in spinal muscular atrophy, or you advice on doing physiotherapy and a pulmonary a respiratory assessment, because the major cause of death of this patient is not linked to the skeletal muscle weakness, but mainly on the respiratory involvement, on the cardiac involvement, and sometimes you have the osteoarticular involvement with contractures that is really prominent. Um, of course, we cannot generalize much about survival. This is related to the subtype and the treating of comorbidities. I stress the fact that you always need to check if there is respiratory or cardiac involvement in your patient. So, what do we do when we see a patient? First of all, we need to listen him or his or her parents. We go through the examination. We can ask for some laboratory tests, for example, the CK level, the serum creatine level. I have a slide on this, but these are enzymes that are found in the blood, in the serum, when the muscle fiber is degenerating. You can do electrophysiological studies, muscle MRI, eventually a muscle biopsy, and if this is a genetic condition, you can do genetic screening. And then after that, you need to get your diagnosis and advice on therapies that can be, as I mentioned before, for SMA and few other conditions we have now treatments, but for the majority of patients, you really need to do the physiotherapy. And when we go through the history, first of all, if this is a genetic condition, we need to reconstitute the pedigree with a family history to determine if this is an autosomal dominant condition, autosomal recessive, X-linked. You need to check for the different symptoms, okay, and observe your patient or ask a specific question, appreciate the progression, and when you do the muscle examination, it's important that you appreciate with particular attention the pattern of muscular weakness. So in muscle disorder, what is very intriguing and very fascinating is that although the defect is present in all the muscle, only some muscle are affected sometimes. For example, the ocular muscle or the proximal limb muscle, or sometimes you have what we call the distal myopathy, where only distal muscle. We don't know what's happening. It's probably related to the protein isoform that are differently expressed, but the pattern of orientation is fundamental for your clinical diagnosis. And then, very important to check if there are associated sign of symptoms, central nervous system disorder, that is prominent, for example, in congenital muscular dystrophy, if there are ocular disorder, if there is a cardiomyopathy, epilepsy, other things that you need to check carefully. And then once you have your examination, history taking, and your um, idea, you need to think about the localization. And if you, I resumed in this slide that the different picture that we can have, for example, in a motor neuron disease, when you have a motor deficit, you can have atrophy and fasciculation. Found in the muscle. This contraction of the muscle can be appreciated, for example, in the tongue or in other muscle. You can have a reduction, especially in children, if you think about the spinal muscular atrophy of the osteotendinous reflexes, and there is no affection of the sensibility. In contrast, if we have a peripheral nerve disorder, we have a motor deficit that is usually more distal than proximal. There is an involvement of the sensibility, okay, and we have absence of reflexes, and sometimes we have atrophy with deformities, for example, of the feet, and um, the with this grief or pes cavus that is typical of the neuropathy. When we have a neuromuscular junction disorder, the weakness, the fixed muscular weakness can be variable. What we have more frequently is a fatigability that can be fluctuating. Okay, for example, a patient can be very active and with a well preserved strength during morning, and then in the afternoon it becomes more fatigable. The ptosis of eyelids appears. There are some problem in respiration, and this is suggestive of something that is fluctuating, that is the neuromuscular disorder junction. But in some of the genetic disorder of the neuromuscular junctions, the congenital myasthenic syndrome, you can have fixed muscular weakness. And then if we go at the last part of the neuromuscular unit, the myofibers, what we can appreciate is a motor deficit that can be global, that can be fascial, that can involve, for example, the extraocular muscle. There is no alteration of the sensibility. The rot or the reflexes can be normal or reduced, and we can have this atrophy associated with cardiac or respiratory involvement. Please feel free to ask me question at any time if you have it, because this is intended to be interactive. Okay, so we have no, I don't know. So do you have a question for now, or everything's clear? Okay, good. So, and then you have to think about a classification of the symptoms. We have negative symptoms where we have loss of something, loss of strength that we define weakness, loss of muscle bulk, atrophy. We have loss of sensibility. We have loss of exercise tolerance, what we call exercise intolerance. We can have the highlights that go down, the ptosis, a problem in the motility of the eyes, the ophthalmoplegia, ophthalmoparesia, and then a problem in ventilation. But in other cases, we have positive symptoms. There is something that is more like or bigger than normal, or something that do not happen normally. Like for example, this tongue that is quite big, these calves that are also big. You can have the myotonic phenomenon, and then you can have stiffness, paresthesia, rippling, that is a phenomenon where you have like waves, contraction of the muscle. And of course, you can also check the elevation of CK level in your blood. And when the CK level are very elevated, there is no general consensus about the limit that we define a rhabdomyolysis, but we think that above 10,000 we can define rhabdomyolysis, which means that there is a massive degeneration of the muscle fiber. That can be on metabolic basis, on dystrophic basis. There are many causes of rhabdomyolysis. But all of these that I mentioned here, like for example the cramps also, are positive symptoms that need to be asked for if the patient do not tell you. And this is most of the time the case in children, because the children do not express themselves as in a detailed way as the adults. And then something that is important to check for is the provoking factor. So is this symptom, these problems happen, for example, associated with fever or intercritical condition, with the cold, for example, the paralysis, okay, or the myotonic phenomenon that are triggered by cold. If this happen when you have a meal that is full of carbs, this is the case of hyperkaliemic paralysis. When you have the fasting, or this is especially in adults, but when you have, for example, the absorption of statins, you can have muscular symptom. And then it's important that the exercise that can be a trigger factor of the rhabdomyolysis. So, what we need to look for when we do a physical exam? We need to appreciate in the children the posture, the presence of a deformation of the spine with the hyperlordosis, the deformation of the spine with the scoliosis, the muscle bulk, check if the muscles are atrophic, normally trophic, or hypertrophic. And then we look at the motor evaluation. You need to make your patient walk, run. You need to make him rising stairs. You need to check for this maneuver that is the Gower's maneuvers. That is a very good hint for a proximal muscle weakness. And then you have to evoke, for example, the myotonia with manual percussion with the hammer or the rippling phenomenon. Okay, how do you evaluate the strength? So usually we have this MRC scale that grade from 0, absence of contraction, to 5, a normal muscle, the strength. This is very important that you do at every examination because you can follow up your patient and see if there is a degradation or not. And once you do this MRC scale in I would say the most important muscular groups, you can then assess if there is a pattern of muscular weakness. Okay, pattern of muscular weakness means proximal, proximal distal, scapuloperoneal, ocular, etc. There are also other scales that are used in specific case, mainly during clinical trials or when we want to follow up exactly a patient. In France, we use very much the scale that is the motor function scale, the MFM. We have some disease specific scale, for example, like the North Star for the Duchenne. We have the NSAD for the muscular dystrophy, etc. But these are mainly in research setting or when the physiotherapists evaluate the patient that are done. With a simple MRC quotation of the muscle strength, you can have a good idea of the pattern of muscle that are involvement and the possible diagnosis of your patient. Then you have to quantify. There are many timed tests, like the 10-minute walk, that we use to make more easily in children compared to the 6-minute walk. I don't know if you follow the
We do that 6 minutes walk. Is it
yeah.
changed now?
So the 6-minute walk is very good, especially in adults, because
Okay.
the adults collaborate very much and
Okay.
can concentrate for 6 minutes in
Yeah.
this task. In the children, what has been showed, for example, in clinical trial for exon skipping
Yeah.
therapies, that this measure was a little bit tricky for the Duchenne patient, especially when they have mental retardation. So now, doing the evaluation of the 10 meters walk, it
Only
is
only 10
only
meters.
10
Only
meters
10
is
meters.
quite comparable
Mm.
with the 6-minute walk. Okay, and the children can do more easily than walking for 6 minutes. That can
So
be
we
difficult.
have to do the 6 minutes.
Okay, then we can have we can measure the ability to maintain the position with upper elevation at lower limbs, and you have of course strength manometers. Now we have these Mayo tools that help us to quantify, for example, the pinch, the strength, and these are particularly useful, for example, in patient with the spinal muscular atrophy that are under treatment, to see if there is an objective amelioration of the strength. Of course, as I mentioned, these time tests are particularly done in adult or collaborated patients. When you have a very young child, it's more difficult to do it. Something that is important that you can do is the drinking test to see if there are dysphagia. And this is a test that is done especially, for example, for test deglutition problem in myasthenic patient. The motor function measurement scale. So this is a scale that has been elaborated. It's very detailed because it evaluates 3 dimensions. The dimension 1 that evaluate the standing position and the transfer. Okay, it's important when you have a disability to know if your patient is able to go from the bed to the wheelchair, etc. The item 2, that is mainly the evaluation of the axial and proximal function, okay, and the item 3, that is the distal motor function. There are 2 versions of this scale. One that is made for children with 20 items, and the other one that is the 32 that is made for adults, where you have more complicated tasks that implicate a cerebral development that's higher.
The physiotherapist is usually the one doing these tests, or the
Yes,
neurologist also.
yes. Can
Physiotherapy.
Physiotherapist?
Okay,
Yeah.
physiotherapist. Okay.
Can we go back because this back this back. Okay, good. Okay, so yeah, the problem with the scale that is very good is that it's very time consuming. Okay, we need, if you are well trained, 45 minutes to do this, and of course, in a consultation with many patients, you don't have time to evaluate. But it's important that if you train physiotherapists, they can do this once every 6 months for the patient in order to have a more precise follow-up. So we thought about the pattern of weakness. It's important to evaluate if there is a ocular involvement with ptosis, the eyelid that they go down, ophthalmoparesia or phamnoplegia, the extraocular muscle, bulbar involvement. So always ask if there are problems with deglutition, if the voice change, you have dysphonia, aphonia. And then very important in children is to appreciate the axial weakness. In many congenital myopathies, you have a prominent axial phenotype with a patient that cannot they cannot rise the head from the bed. Okay, so you need to check the neck extensor, the flexor, and also the abdominal muscle. Then you have the limb girdle muscle strength. Okay, scapular and pelvic. You can have a pattern that is particular with the proximo-distal distribution of the strength, so the scapular girder and then the tibialis anterior or the other muscle. And then you can have also very distal myopathy where only the fingers or the hand muscle are touched. Here are some examples. So what do you think this patient has? What is the pattern?
يعني احنا عايزين نبقى interactive، نقول رأيكم ايه، العيان ده عنده ايه. يلا يا محمود، في مايك محدش مع برنا مصر 2000.
ممكن نقول بريفرال نيورو بس.
Yeah.
ممكن نحط ديستال مايوباثي.
Yeah. Or
some type of Duchenne.
المايوتونيك ديستروفي برضه في الادلتس بيبقى ديستال ابر وديستال لو.
this is true. This is true. Yeah. Then you have the neuropathies, for example. You have, yeah, good. The distal spinal muscular atrophies.
Today you have this draw of the motor unit, so you can think what is anterior horn cell can be distal. So the distal type of SMA, this is an atypical SMA, the distal myopathy, the myotonia dystrophica, the peripheral neuropathy. So you can widen your differential diagnosis, not only one diagnosis.
Yes, and then here you have a pattern that is specially localized in the face, with these pharyngeal muscle that are touched, the facial muscle, and then the eyelids muscle. Okay, and here you have what is this according to your knowledge, where you have ocular involvement, facial involvement, axial, respiratory, and then distal. I think you mentioned already. Yeah, and the Steinert. Huh? This is probably a patient with a Steinert. Okay, so we mentioned the pattern, and then we have to trace what is the disease trajectory, the natural history, and always follow the age at onset that can be very early, neonatal, or sometimes antenatal. Always ask in condition that start very early if the mother could feel the movement of the baby during the pregnancy, if there was hyperhidramnios, if there was fetal akinesia that can be seen easily with ultrasound. And it's important that you ask to the mother to compare from other pregnancy. For example, someone can tell you, okay, the first born moved normally, but the second one I didn't feel it at all, and this could be a sign of antenatal neuromuscular involvement. And then, of course, you need in the infantile time to check for the motor milestones. Okay, what are the most important motor milestone that you need to ask for in a small children? So yeah, so the support of the head, time of sitting, time of yeah, and there is another important thing that you can ask if the breastfeeding was effective. If the child, yeah, could suck efficiently. If she had some deglutition problem, okay, during sucking with regurgitation. If the cry was weak, uh, this also is a symptom of generalized weakness. If there was drooling, drooling is another sign, an indirect sign of altered deglutition. Okay, and then the mode of presentation that can be acute, subacute, progressive, like in the dystrophy. In general, the genetic condition are not abrupt, but is something that can be manifest very severely from birth, but then can ameliorate, or you can have a weakness that go progressively increasing. And then if you have, for example, uh, elements that trigger the weakness, like in the periodic paralysis, if you have a fluctuation, like in the myasthenic syndrome, and then the triggers that I already mentioned, the alimentation, like for example the carbohydrates, the effort, some treatments, and the fasting for the children. There are forms of rhabdomyolysis that can be really, really life-threatening for the patient, especially young children that are triggered by fasting. Okay, and then for specifically for the pediatric population, you have specific elements to evaluate at different age. For example, in the neonatal period, you need to observe the patient if he has hypotonia with a floppy baby. I have 2 slides on this. Deglutition problem we already mentioned with the drooling, the incapacity regurgitation to attach to the breast, lack of movement, There is the arthrogryposis. Do you know what does it mean? Okay, when you have multiple contractures that appear at birth, that is an antenatal sign of reduced movement in utero. You can have the malformation like the club feet at the birth, can be a sign of associated with a myopathy, for example, congenital torticollis, okay, also associated with, for example, for collagenopathy, and then, of course, the respiratory and cardiac involvement. And a patient, of course, that need ventilatory support, uh, you need always to make the differential diagnosis between a central hypotonia or a peripheral hypotonia that is related to neuromuscular disorder. In older children, what is important to evaluate is some hypotonia stay, the motor delay with the different motor acquisition, motor milestone. The failure to thrive is another sign that is important. So the patient cannot gain the weight as the normal feature. And then the frequency of respiratory infection is another indirect sign of myopathy. In older patients above 2 years and adolescents, you need we suppose that this patient can walk, okay, and sometimes one of the first sign that is appreciated by the parents is the fact that the patient fall frequently, okay, and when they fall you always need to ask if they are able to rise up unaided or not, because this is another sign of motor weakness, in particularly proximal motor weakness. So the rising from the floor, gait abnormalities, walking on Achilles with Achilles tendon retraction. Okay, running difficulties, cramps, fatigue when they are in school. For example, a sign of muscular weakness is the fact that they are very slow in writing, and although they do not have central nervous system involvement, sometimes they are children that are thought they are slower than other mentally, but it's not mental, it's only a problem of muscular weakness. And then, of course, in older age, you have to evaluate to see if there are difficulties in sports compared to his or her peers. You have conditions like the congenital myopathies that can be very mild, and the patients that attend only at older age can tell you that, for example, they were considered lazy, they were considered as the slower in the family, but nobody thought that there was a medical condition underlying this not real laziness but muscular weakness. Okay, so the floppy baby, you can see here with this anti-gravity movement, the parachute maneuver. There is the absence of movement against gravity. There is an absent response to pain. There is anemia, drooling. You can have a weak cry, deglutition problem, and respiratory distress. Of course, you need, when you have a floppy baby, you need to make the distinction between central nervous system problem or peripheral nervous system, that are the neuromuscular disorder that we are treating today. And when you have a floppy baby, you have, of course, a lot of differential diagnosis, a lot of possibility: SMA, congenital myopathies, congenital myotonic dystrophy. So always examine the mother to see, or the father, to see if they have a myotonic phenomenon.
Can I ask in this point the congenital myotonic dystrophy?
Yes.
I previously thought it is only the mother is myotonic, but you now said that maybe the father.
So there are, in general, is the mother that transmit a higher number of triplets, but sometimes there are cases
So
inherited from the
in
father.
congenital myotonic dystrophy, we must examine mother and father, because I usually ask about the mother, but now this is a new information. Okay. Do you want to take your coffee first and
No,
take
it's
her?
okay. It's okay. It's okay. Thank you. And then it's important the posture to observe your child. Okay, you can see here this like frog-like attitude of the legs. Look here, look the deformation of the thorax, and then with the anti-gravity maneuver, you can really highlight the presence of axial weakness with the flexor and extensor weakness. Okay, and then when they are older, you can see here this deformation. How do you call this? Yeah, kyphosis. Here, what you observe, you don't have so much of kyphosis, but you have this abdomen that is kind of prominent, and this is probably due to abdominal
Abdominal
weakness.
weakness.
And here, what you have? Hmm? Lordosis,
Lordosis.
exactly. But also, you can observe here that you have
Tip. Yalla. Tip 2 or talipus. Tip 2
talipes, yeah,
walking or
tip to
talipus.
walking or Achilles contraction. Okay,
Yes.
and here you can have hyperlordosis, this abdominal
Abdominal
like
troubles.
proeminency, and then you have the
It is
talipes.
very important to unbear the child.
Yes,
So
yes,
we can see this posture and we can see these muscles. So here it will be in a private part in the clinic, and you must unbear the patient to see all of these details. You cannot see while he is wearing his clothes, of
yeah.
course.
This is important. We need to appreciate the muscle, examine them, see if there are like abnormal movement of the muscle. So you always need to perform an examination with the patient without clothes, of course, wearing underwear. Okay. These are other alteration. What you have here? It's written here, but what do you observe in this picture?
المصل فيها ايه؟ hypertrophy.
Yeah,
Yes.
so you have the very muscled.
We have a question yesterday from Yusra, our lecturer of neurology. She was asking in what was the question, ya Yusra?
Yeah.
Okay, but can you give your question because I couldn't ask her.
I was asking about the hypertrophy in Becker muscular dystrophy. Is it always pseudo hypertrophy, or there is compensatory hypertrophy in some muscles through hypertrophy?
So the mechanism are really not completely known, but we used to say that it's pseudo hypertrophy, okay, in Duchenne and in Becker muscular dystrophy, because when we do muscle biopsy, we see that some fiber are hypercontracted, okay, and are bigger than the other, okay, the hypercontracted fiber, but there is fatty substitution, okay, and fibrosis, and these start very early. We have done recently an analysis on the muscle biopsy of Duchenne patients and Becker, and we see that already at early age you have a fatty substitution. Therefore, probably this is not a real hypertrophy, but it's pseudo hypertrophy. So yes, this is an hypertrophy because you have a defect in a channel that provoke easier contraction of the muscle. This was a patient with a recessive chlor channel defect, and there the muscle is really trained.
All,
Okay.
most of the muscles of the body as athletes, you will have hypertrophy
Yeah. And
all
I
over.
think this condition, you have a many patient like
Yes,
this
I want to.
in Egypt.
Yes, I started to see many patients of this after Professor Ud come from Finland. Before he came, I missed a lot of these cases until one mother brought her child. He was about 3 years old, and said that he has difficulty of walking. Then I examined the child. He was very good walking and running, and all the reflexes intact. The muscles are very good. It was not so bulky muscles. Then I told her, your child is normal. Then she said, all the doctors tell my child is not normal. Then I asked her to do a home video. When she did a home video, I discovered that at starting of movements, he couldn't walk. He even cannot go upstairs. He cannot run. Then, when he came to my clinic, he was playing outside, so he was normal. Then, when Professor Otkam, he told me that this is congenital myotonia. After that, many patients are diagnosed in our department now. We have many patients.
Yeah, because this patient becomes stiff, okay, stiff, and they cannot move. And the myotonia is sometimes triggered by cold, but as here, the climate is not so cold. So, but sometimes patients tell you that when they eat like a ice cream, they have myotonia of the tongue. So carefully ask for these kind of tips that put you in the right diagnosis. So on the other side, what we have here is a prominent atrophy and wasting of the patient. This is a patient that unfortunately deceased. I saw him in 2018, and it happened through genetic screening that he had this homozygous variant in TK2 gene, and this is very unfortunate because now we have a treatment for this condition that are the cocktail of nucleosides, the mitochondrial disorder, and there is a clinical trial ongoing in US, and the patient that used to
I have
decease.
to check because I think I have a patient genetically diagnosed. I will check for
Yeah.
this patient.
So these patients with TK2 variants that are recessive, so either homozygous or compound heterozygous, they develop a depletion of mitochondrial DNA. So the mitochondrial DNA is deficient, and they make this metabolic crisis and wasting. But replacing the nucleoside that help the synthesis of mitochondrial DNA,
cocktail
they have nucleosides. Okay, the bases like cytosine, guanine, etc., that can synthesize new molecules of mitochondrial DNA.
It is sold in the States or also
So it's
in
you
France?
can find out of label,
Okay.
off label, sorry. And we have a patient in France that are under the clinical trial, and the main clinical trial is in Spain and in US. But
Okay.
if you have patient, I can put
If
you in
I
contact.
found the because I know that I have a patient like this. If I found it, I will ask you about therapy.
Yeah.
Every
And
day
these
new
are
therapy.
patients that if remain untreated, they disease,
Mm.
and we can treat them.
But at this stage, I think you will not respond to any therapy.
So
After all of
they
this
can,
atrophy.
yeah, of course, this was very compromised, and he had a very important respiratory involvement. But I think that we could have stabilized this child. So yeah, it was very unfortunate. Anyway, then look at the back. Look at the back, and you check for the scapular winging. Okay, what is the scapular winging? What is the muscle that is deficient in this kind of
Scapular
alteration?
winging. Main muscle is ها قول يلا serratus anterior. Yes, this is the main muscle causing this, but there are other muscles can cause scapular winging. Trapezius.
Exactly.
Mm.
And what is very interesting in this patient, and especially in this condition, the scapulo-humeral muscular dystrophy, and then the deltoid muscle are preserved. So if you fix the scapula of your patient, he can do a normal elevation or pseudo-normal elevation and abduction. So it's
Do you
not a
do
problem
these
of the
operations of fixing the
so
scapula in
yeah,
France?
sometimes the patient mainly for aesthetical reason tell
Yes.
us we can do it's a very complicated surgery, and then you cannot go above
Yeah.
90 degrees. So aesthetically is good, but you do not gain very much. What we suggest for this patient is bracing. Okay,
Yes. Yes.
that fix a little bit. I have some patients that utilize, others that do not. It's
Very poor
dependent.
condition. We will talk about FSHD because we have a problems is the genetic diagnosis and management of FSHD. So maybe today we have a long, Dr. Normin.
Yeah, of course.
Normin genetics. She's a specialized in medical genetics. From the last visit.
Yeah.
So we have a lot to discuss with you. We have a problem in FSHD in Egypt We cannot diagnose them properly.
It's complicated
yes.
because the genetic is linked to this macrosatellite region of the chromosome 4, where you have this Z4 repeated unit region that in patient is below 10, okay, while in normal person that do not have FSHD is above 10. But this is not the only defect because you have a problem with methylation, okay? And you have an homologous region in another chromosome that is the 10 chromosome that also have this repetition, and the alteration should be in the chromosome 4 and in a specific allele that is the 4A allele. So you need to have this contraction that is in the 4A allele with an epigenetic relaxation that provoke the production of the protein to demonstrate its presence in muscles. Okay, so this is a working hypothesis that has been elaborated, but mainly we are not completely sure that the culprit is DAX4. And the genetics is complicated because you need to do Saturn blot, and then we have a molecular combing now in France that allow to determine if there is epigenetic relaxation and to quantify exactly
It
the number.
needs a specialized laboratory. Not every laboratory can do this, I think so.
You need personnel and
Yes,
time
personnel,
and
yes, yes. You are right.
and
yes.
a good machine to do
Yes,
molecular combing. I think.
yes.
What you do here?
We do through centogene. They have we do the
Okay.
whole exome. What we can do is a whole exome. Ah. We can uh, he told me that they have two genes of type 2 on the whole exome, so through whole exome. But type 1, they don't do thousand blot, so we cannot diagnose type 1.
Yeah. In France, we have two labs that do this. The lab in Cochin, France Les Turcs. I don't know if you
She
met
was
them.
in France, she know about them.
Yeah, and then in Marseille with Raphaël Bernard.
Christophe Bureau.
Yes.
But he told me that it takes long time, probably 3 months. So we tried to arrange for it. But
Yeah.
this was a few years ago.
Yeah. Yeah. Yeah.
I think now
We can arrange if you have another lab in
can
France.
do it faster. Takes time.
So it depends because now they restarted to do the techniques in Paris, okay, and they do now another technique that is called nanopore that help quantifying the region. But it's very long to get the results. In say now it's about for us to get the result it's 6 months.
6 months.
احنا طبعا
But the experiment, I think it lasts like 1 week or something like that.
يعني I will explain.
We can arrange for.
We were asking about the genetic diagnosis of FSHD because type 1 needs 1,000 blood, as professor said, and it needs a highly specialized personnel to do. So this is important because of the clinical trials of FSHD. But type 2, we do the genes of it through whole exome. So we will discuss this, how we can diagnose our patients in Egypt. We don't have the facility for genetic diagnosis of type 1.
Yeah.
So
And the 95 of form are type
yes,
1.
type 1,
While 5% are
95%.
type 2.
Yes.
In type 2, you have this SMCHD1 point mutation, but they need to be associated with the relaxation of the chromatin. Okay, so they
I think when there will be a therapy, the companies will help us to diagnose our patients.
yeah. So yeah,
Okay.
it's a complicated issue.
Yes.
Okay. But scapular wing, it's not only seen in FSHD, could be seen in other conditions like limb girdle muscular dystrophy, in Pompe disease. Okay, I think,
Calpain, yes, calpain, Pompe.
calpainopathies, congenital myopathies. It's very unspecific. Okay, and also in Pompe, in Duchenne. And then you need to appreciate the atrophy. The atrophy where is localized. Here you have a patient with a prominent bicipital atrophy. You can see here also the facial weakness. This is a congenital Steinert patient. You have a alteration here of the pectoral muscle with the appearance of this axillary fold. Here the falling shoulders with this axillary fold that appear. Also a patient with FSHD with the formation of the thorax. So you need really to carefully analyze your patient, not only test the strength, but see where are the atrophic muscle. And then look here, your question before, we tend to say this is pseudo-hypertrophy of the calves that is suggestive of the dystrophic process. Of course, Duchenne in Becker 2 and progressive muscular dystrophy. Sometimes the mother of Duchenne patient,
Manifesting carriers.
the
yes.
manifesting
We have
carriers,
many in
they
Egypt,
can have
yes.
this. And the manifesting carrier is a big problem because they can have isolated cardiomyopathy. They can have a muscular disease that is very important. They can have only elevated CK.
Yes.
Okay, so
in all carriers, we do now echocardiography, and we follow up the mothers every 6 months. Even if she is only
asymptomatic.
if she is asymptomatic, we do this now routinely. We do the mother, the manifesting carrier, the only high CK, or even asymptomatic. We must examine for the heart every 6 months to 1 year.
Exactly. And then we need to check the proximal weakness. When you have a pattern of limb girdle muscular weakness, you can see here the patient cannot make an abduction, cannot make an elevation. Look here, she has a deficit that is milder than here, but this is not normal because usually the children can rise the end up and without problem. And then check also the deformities, okay, that you can have. We have talked about talipes. We talked a little bit of the pes cavus that is especially seen in neuropathies. And then you can have a varus deformation or echinovarus deformation like here. Gower sign. Okay, this is the most sensitive measure to appreciate for proximal muscular weakness in children. And you can see here this boy, okay, cannot rise up, and then he has to do this appendicular movement and push on his quadriceps because what are the deficient muscle here? Which is the muscle that
What?
do the hip flexion.
Yes. What is the most affected muscle here? حد تاني غير محمود اللي هي بتعمل هيب فليكشن.
Psoas, ellipsoas. Very good. And there is another patient. Okay, she is less affected than the patient before, but still she needs to push, to pull on her thigh to go up. And then the walking aspect. You can recognize a patient when you arrive to your consultation. Look at this patient. So what you observe here. How can you define the way of walking of this patient?
حد يوصف لنا المشية بتاعت العيان؟ يلا يا جانيت. Waddling gait.
Yes.
Tiptoe walking.
Very good.
And lordosis.
Very good. So what is your most, if you look at the calves, you can also think about a possible diagnosis here.
What is the diagnosis? Samira? Diagnosis. سليمة؟ لا ده قبل الليم جاردن. Boy, Duchenne. This
Very
is
good.
Duchenne. This is immediately before he lose ambulation.
And look
This
at this.
picture.
This is very interesting because he has some similar with this compared to the one, but it's different. You want to see again? Maybe?
Yes. It's not the same boy.
No.
Ah.
So, do you think that he has a Watling gait or not? Come on, there is no. Even if you are wrong, there's no problem.
No problem if you are wrong. وعنده ايه بالظبط؟
This is true, but he has also a proximal muscular weakness of the pelvic girdle. But what is interesting is not stable. But look at the feet. Is this like the other patient or not? So he doesn't have a tendon contracture, but there is weakness in the feet.
Distal weakness.
Yeah, so there is
Distal
proximal
weakness.
and distal weakness,
Ah.
and this hyperlaxity that is visible in the upper limbs.
But he was collagen 6?
Yeah.
Collagen 6.
And then look at this.
Okay.
It's written, so it's easy.
يلا قولي يا يسرا. High steppage.
Steppage, foot
Yes.
drop.
High steppage, foot drop.
Okay.
Okay. Distal. Okay. It's
And
very important.
And look at this. The patient on your left, she has a neuropathy. The other one is distal myopathy. Okay. There is a trick that learned to us Dr. Wood, Professor Wood, to distinguish between a distal myopathy and a polyneuropathy.
Yes.
Do you know this?
Yes. قالها لنا Professor Odd. The extensor digitorum brevis muscle.
Exactly. Is
Okay.
this
If it is
muscle
intact.
that is here. Okay.
Okay. Yes. They know it.
Very good.
If it is intact, so it is more distal myopathy. If it is atrophic, so it is more a peripheral neuropathy. Because the distal myopathy is rare and we don't put in our mind that he may have a distal myopathy. But when we do the EMG, we found a myopathic pattern. So why he will have a myogenic pattern and it is this? There are rare types of distal myopathy. So Professor Odd from Finland told us that most probably if we found the extensor digitorum brevis muscle is intact, so it is myopathy, and if it is atrophic, it is neuropathy.
And you know how we do examine this muscle? Maybe I can show you.
Yes.
So you have your feet like this,
هم عارفينها اللي بيصلوا عليها.
you make, you look at your toes and you touch the muscle here. Okay, you can see there is a contraction
Yes.
here. Okay,
Yes.
and
They
it's
do.
very important
It
for
is. It is well formed in your foot.
Good.
It is bulky here. This is an important differentiating point because Dr. Oud is specialized in distal myopathies.
That are very frequent in Finland.
he know about 30 types of distal myopathies of all age groups. So, okay.
So, and then, okay, if you have some doubts, ask the parents to send you videos, okay? Videos of the stairs. Look here.
Home videos is very good.
Home videos is very good because there is no stress. Sometimes the children, when they arrive, they cry a lot. They do not want to be examined. So ask the parents to do home videos. So what do you see here? I'll put again.
This the girl.
Are these children normal or not?
The one with the white, I think she is good. Not so much.
Not so much.
Huh? Quadriceps affection, Dr. Lobna said.
Exactly. Look. There is a look carefully. There is an hesitation. There is a.
Oh, but she can do one by one. It's very good for our patients.
So look,
Okay.
she hesitates.
Yes. Yes.
Which side? I want to know which side is more affected here.
Left side. No, right side. Both sides.
I think left side is more effective.
Okay.
Okay. Then we look back the other one.
Ah,
Tech,
the-
tech.
ah.
Sorry, I do a
This
disaster.
the green one.
The green one.
Okay. Oh, more affection of the left side,
Yes.
proximal weakness, and I have to.
And he used the banister. Okay.
Yes.
So he make a leverage on the right leg
Mm.
in order to overcome the muscle weakness
Yes.
of the
To
psoas
help the
muscle
left
and the
one.
quadriceps muscle. Okay. Tac, tac, tac. I'm, and the third. I'm sorry.
The one with
I
the
make a
blue.
lot of disaster.
Oh,
Up. Now. No. Because.
it doesn't want to come.
No.
It's okay.
Now. Yes. Okay. Okay.
The third one
The third
with the
one.
blue. يلا مين هيقول لنا دكتورة نسيت اسمك ابتهال قول يوم يلا يلا ها proximal weakness
على الليفت سايد.
left side.
Okay.
Okay.
Very good.
Very good.
Then fascial weakness. Okay, what you serve here, you have this ptosis in this child. You have this open mouth with prominent fascial weakness. Same here. This is the congenital Steiner. Same here. This is another myopathy. And then you can appreciate the smile with this inverted smile here. And there is like the horizontal smile that can be seen in Duchenne patient. Okay, don't always look the face and check the orbicularis oculi. Okay, in the normal patient you have the possibility to close tightly the eyelids. In FSHD, you have a problem of the orbicularis oculi. Sometimes the patient will sleep with open eyelids, so you need to ask this to the parents. But you have this condition in this alteration in many other conditions, like a congenital muscular dystrophy that you can see here, nemaline myopathy, in myasthenia. This is another congenital myopathies, the ryanodine one. And then, of course, you need to observe very well the extraocular muscle weakness. Okay, the orbicularis oculis is derived by which nerve? Mhm. If you do this, which are the nerve? Sorry? Facial. But if you have ptosis, which is the nerve that is involved? The third. Okay? So the ptosis is a problem of an extraocular muscle. Okay, the third one. The ptosis can be symmetric, can be asymmetric. Okay, there can be a fatigability, so you can test with the upward gaze if the patient tend to
look up until he has a fatigue.
exactly. And then you need to check the ocular movement. And here we have videos. Look at this patient. What does he have? We are testing the face, but look at the eyes. He has complete ophthalmoplegia, and look at this one, other patient. Look, we are trying to make him look in different direction, and he can't because he has a completely ophthalmoplegia. And these can be seen in many conditions: Steiner, myasthenia, mitochondrial disorder, congenital myopathy. This is very interesting. The last patient that I showed, it's a nemaline myopathy that usually do not show this kind of ophthalmoplegia. It's an exception. Orbicularis facial nerve, again, okay, possibility to whistle, okay, the patient cannot do, but of course they need to be a little bit older to ask this task to them. And then if they can blow their jaws, and then you can simply ask them to make a kiss to see if there is an asymmetry that is particularly evident in FSHD patient. Okay, sometimes In FSHD patient, the facial weakness is not very prominent. If you make the patient give a kiss like this, you can sometimes observe it. Then you make your patient open the mouth and appreciate the tongue. The tongue can be hypertrophic or pseudo-hypertrophic with the macroglossia in many conditions, Duchenne, Becker, FKRP, that is limb-girdle muscular dystrophy, or congenital muscular dystrophy, sarcoglycanopathies, and
Pompe,
Pompe.
large tongue.
In Pompe, you need to test the strength
Yes.
of the
yes.
tongue. That is very important. And if you have muscle MRI, you see that the tongue is affected.
Yes. In muscle MRI, there is fatty infiltration of muscle.
And something that is really important, especially for congenital myopathy and congenital muscular dystrophy, is the deformation of the palate with this ogival or high arched palate. That means that there was like a reduced movements in utero, and the palates cannot develop easily because the muscle cannot move. Okay,
عايزين
so
نزود وقت.
always check for this. Contracture, we always check for this, especially in the Achilles tendon with the talipes. You have a major contraction in this condition that I think is frequent here, the Lama2 tyrosine
Yes, we
deficiency.
have a series of Lama2.
And these are patients that can be
Just a moment, we will add. How many slides we still have? This is an
maximum. No, I
maximum.
think in 15 minutes we are
okay,
done.
we will
done.
finish and it's okay. But this is an interactive because it's important to ask and discuss and answer and do wrong answers. I still do a lot of wrong answers until now. So this is a way of learning.
Yeah, and then you need to finish this class and be able to examine in a
Yes.
detailed way a
They
child.
have to practice and do this, experience these signs. These are keys of diagnosis to find ocular affection, to find tongue, to find facial. This is a keys of diagnosis of certain disorders.
And contracture can be localized, of course, at the Achilles tendon, but can be here in different muscle. You can have it on the fingers, so at the knees. So you really need to check for this, okay? And this is important to check because you can fight against the contractures with physiotherapy and simple exercise that you can recommend to do to the parents of your patient at home. So it's very important, and the contractures are important to maintain the stability of the patient and the gait. Okay. Rigid spine, when the contracture is localized at the back. Look at this patient that he can't bend the spine to take this object, so he has to make a flexion, okay, because it's very rigid. And this can be seen in many conditions: Pompe disease 2, calpine deficiency, tendinopathies, Emery-Dreifuss muscular dystrophy. The skin, other thing that is very important. In congenital muscular dystrophy linked to collagen 6, you have skin abnormalities with these alteration that we call the follicular hyperkeratosis. Sometimes it's less prominent. The skin is like how do you say when you have it's not smooth. Yeah, the contrary is smooth in English. I lost the term, but it's not smooth. Okay, it's irregular. Okay.
Rough.
Exactly,
okay.
rough. And then you need to see if there are like keloids that are like there is a problem of bruising that is not.
I think
correct.
we have patient like this because Dr. Nermin said this would be a collagen 6. We must report this case. We have a lot to report.
It's very interesting. And what is very important to see in this patient that you have these skin abnormalities, hyperlaxity, and contracture. So
Yes.
the association of these two conflicting.
But how many patients, the percentage to have skin abnormalities?
So if you look well, you
Mm.
can find in the majority of patients.
Okay.
Okay, so
Because
always check.
we have some patients with collagen 6, only this patient that he has a picture like this. But we have to examine other patients.
Yeah.
And
And the
keloid formation. Mm, mm, mm,
Yeah.
mm.
Then it depends because in the collagen 6 you have the most like affected patient with the uric congenital muscular dystrophy, and then you have a milder form that can secrete some collagen that are the Bethlehem myopathy that are milder, and you don't have the full phenotype, full blown phenotype.
But we have in Egypt collagen 6. This is very important in diagnosis. Yalla.
It's a very important question because sometimes in the collagen 6 through the contracture you can still walk, but sometimes you lose the walk very very early. And what is dramatic in this patient that is more the contracture that make the loss of gait, because if you test their quadriceps are pretty good, but they are so contractile that they cannot stand anymore. Okay, so it's a matter of strategy to see according to the motor status of the patient, and then it's very important in the collagen cyst to take care of the respiratory function because they have a diaphragmatic alteration, okay, weakness, and the thorax is very very contracted too, and so you need to expand and to use machine like cough assist in order to make this patient breathe. But they are very patients that are very very delicate. Okay, so the fight against contractures is important, but sometimes if you make a surgery of the contracture, the patient can lose the gait. So we always need to evaluate.
Assess every patient's individually.
And then you have the abnormal movement. Here you have the fasciculation. So here the diagnosis is pretty simple. What has this patient with the
What is the diagnosis? ما عندناش غيره اسم ايه؟ We must look
Be
for
very
the
careful and check always the sign, because the SMA, especially type 2 and 3, can be type 3, I would say. They are very proximal, okay? They're very proximal. They can mimic a muscular dystrophy.
Yes.
But if you check the fasciculation, you
Tremors,
can diagnose and treat. What you have for treatment here in Egypt?
We have the 3 drugs, but one covered by the government and the other 2 still. But we have the 3. We treated with the 3 drugs.
Okay,
now.
so you have a risdiplam that is
Yes,
covered?
yeah. Risdiplam is registered, but still not covered.
And,
But we will try.
Nusinersen is...
Nusinersen is still not covered, but they give Zolgensma for infants below 6 months. This is the one covered.
Asymptomatic or...
No.
How many copies?
2 copies and more. Okay. But we are, Dr. Hani Tahir with us in the committee, we are fighting that we give asymptomatic, because symptomatic, we have many troubles with the patients. So either we are now starting very early as we can, but we want to do neonatal screening, still fighting.
Okay, good.
What you have in France, I think that...
Yeah, we use, I have experience with adults, both Nusinersen and risdiplam now, and we have good results.
Yes. Is it covered?
Is it covered?
Yes.
And yeah, so maybe the next time that I come, I will present you our data on adult patients. So
okay.
Of course, we cannot make this patient walk again, but we can have important amelioration of the distal strength. They can ameliorate the life. But of course, it's a matter of price.
But they deserve. Adults, children, all deserve therapy.
Of course. So we are almost finished. Once that you have done all these examination, you need to check for the associated signs and symptoms, the cardiac, with the presence of cardiomyopathies, arrhythmias, the respiratory involvement that is in particular important for metabolic myopathies, and other alteration. For example, the deafness can be associated with infantile FSHD. The Brown-Vialetto-Mollare syndrome, that is a deficit on riboflavin
This
transporter.
is very important. Can you tell them about this syndrome? Because this is a type of SMA.
Yes. So this patient can develop a very progressive muscular weakness that mimic an SMA, associated with deafness, deglutition problem.
Yes.
Okay. And this patient, if they are supplemented with riboflavin, they ameliorate. Otherwise, they can
So what is important, because we have one patient in the department 2 years ago. العيان كان معايا شادي سامي فيه. This patient has proximal weakness and manifestations like SMA, but it was associated with bilateral deafness and bulbar that was severe. The patient was cachectic. But when we check that it is this Brown-Vialetto syndrome, they have a defect in the riboflavin
transporter.
transportation. So if you give
SCL30
Yes.
something gene.
if you give riboflavin in high amount, it is curative, and you can help your patient. Even the deafness, can you help your patient? So please read about this syndrome. It is present. It is rare, but we found one patient like this.
And in adults, if you see adults, you can have polyneuropathy
Uh-huh.
that are associated
Okay.
with this.
Okay.
So it's very important. Okay, then, well, I already told the cataract is important because can be found associated with Steiner, mainly in adult patient, and then, of course, ophthalmoplegia, very important to detect. Myalgia, contractures, we have seen, rigid spine, finger contractures that are very important to detect in the patient with this prayer sign. And then hyperlaxity, of course, diaphragmatic weakness that can be a revealing symptom, for example.
Yes, I want to
pompe
ask
disease.
about the diaphragmatic weakness. Do you do just clinically, or sometimes here we do ultrasonic of the diaphragmatic muscle?
Yeah, we can do the ultrasound.
Yes, this is very important, and it is easy now. Our colleagues in pulmonary and chest departments, they do ultrasonic of diaphragmatic muscle.
And then you have this syndrome, maybe you have heard about it, the Schwarz-Jampel syndrome, that is very easily to recognize because you have dysplasia, short stature, muscular pseudo hypertrophy with myotonia, and the mask fixed face with blepharophimosis. And diagnosis. Okay, we have seen the clinics, laboratory biochemistry, mainly serum CK, electrophysiology, imaging, muscle biopsy, DNA studies. Just a mention of the creatine kinase that is very important because C282 in the field of myopathies where CKs are usually mildly elevated or normal, or muscular dystrophy where the muscle fiber degenerate and you have high elevation. Above 10,000, we say it's rhabdomyolysis, massive degeneration of the muscle that is important to detect and to prevent because the patient can go into renal failure. Okay, pattern of weakness and serum creatine kinases. So in general, normal metabolic congenital myopathies, Steiner sometimes elevated, FSHD could be elevated, and then if you go up in thousands, you go into the muscular dystrophy, of course, Becker, Duchenne, etc. EMG studies, challenging in young children. Okay, you need to have a specialist of this, and it's particularly useful for myotonic syndrome, myasthenic syndrome. You have a specific protocol for periodic paralysis and, of course, neurogenic disorder. The myotonia that I think everybody knows that is associated with a specific pattern at electrophysiology. This is like a plane that go in a diving bomb. And then muscle imaging that is very important. We have the pattern recognition that can be applied to muscle MRI. So you can see, for example, this is a patient with a dystrophinopathy, where you have in the legs the gastrocnemic that are white, so they are altered, while a patient that has a similar pattern without the gastrocnemius muscle could be a sarcoglycanopathy. That is, gamma sarcoglycanopathy is the most common differential diagnosis of a Duchenne muscular dystrophy patient, especially specifically in countries where the endogamic level is very high, like I think in Egypt.
Yes, we have. We have many.
How much do you think that you have of consanguineous marriage? Which percentage?
Consanguineous, 40%.
40%?
Yes, 40% at least. You have a work like this in your hospital. You said that. Yes, you have a publication. They said about 40%.
Yeah, this is of course not good for the patient,
Yes.
but you have a lot of work because you need to recognize the autosomal recessive disorder. And then I wouldn't talk here about
Genetics.
the biopsies, but the genetic studies that now are the first line diagnostic approach after the clinical and the labs that I mentioned before, with these next generation sequencing techniques that allow to sequence massively and in a parallel way different fragments of DNA, different genes, panel of genes. You can have exome sequencing, you have whole genome sequencing. This is very important, and be careful because it happens to us that exome sequencing could not reveal large rearrangement that were detected by the GGH array. Okay, so the whole genome can detect it, but the exome, it depends on
MLPA,
and the MLPA, of course, is
MLPA,
important, especially for Duchenne muscular
Duchenne and
dystrophy.
SMA.
Okay, and SMA. Well, from the first recognized entity that was Duchenne muscular dystrophy, now we have around of I would say 600, 800 loci or genes associated with neuromuscular disorders, so a lot to go through, but still the most common phenotype are easily recognizable, and then there are rarities that we need to proofly study in order to get to diagnosis. And what is interesting, I think, in the neuromuscular field, and now we have many therapeutic avenues, clinical trials, so it's a very fulfilling field that now we can treat our patient, at least some of them. The NGS is not always successful. We have diagnosis in around 40 to 50%. And in the other case, we have this big conundrum that are the VUS, variant of unknown significance, that sometimes are difficult to ascertain in terms of pathogenicity. And in some cases, they can reveal candidate genes or new genes or give new results. And this is something that we we face every day in our routine. This patient with the congenital myopathy, he had different variants, okay, in different genes like myopaladin and nebulin that are associated with the congenital myopathy. Also this gene one, but which is the good? So you need to go back to the clinic, see if it makes sense. If it do not make sense, redo, make another techniques, and in this case you need the muscle biopsy to verify and validate. Take home messages. So neuromuscular disorder are related to an impairment of one of the components of the motor unit, okay, motor neuron, peripheral nerve, the muscle, the neuromuscular junction. The common denominator is a weakness, a paralysis that can be variably severity and can have a variable prognosis. They are rare but not so rare, and they mainly affect children for the genetic disorder. Okay, and they are not curable for now, but they are treatable. We have some drugs for SMA, we have something for the Duchenne, and also for the metabolic myopathy, we have mentioned before the brown vialetto, where with the riboflavin supplementation we can resolve the patient. And then you need to insist with your patient with supportive care, physiotherapy, that is very important, respiratory care, and cardiac management. Thank you very much.
Thank you so much, Professor Eduardo Malfatti. Usually, he came and give us his science and experience and add a lot and lot. This is the third or fourth visit, third visit to Egypt. This COVID-19 let him away 3 years now, but okay, we hope it will be yearly. So now we will have more and more students and colleagues in Egypt. They came from many universities, hostels, and research institutes to share with us this school. So I think we have increasing number every year. So as you see, yesterday and today, you must have a system in your brain. You must have the motor unit and search for disease. And you must read. You must read these disorders by yourself so you can apply on what you found and you will learn a lot. You can treat patients. You can treat patients with osteomyelitic myopathy or vitamin D deficiency. These patients, Brown-Violetto syndrome with riboflavin deficiency. Now the SMA patients is treatable, the Duchenne, some mutations treatable. I want to thank Professor Eduardo Malfatti because in his last visit, he told us about the panel of inflammatory myopathy. There is a panel of these myocytes associated or specific antibodies, and we succeeded to have this in our immunology unit in the hospital. And we have now about 40 antibodies for muscle specific and associated. And now we have Dr. Yusra, her doctorate degree was about immune mediated myopathies. And how many patients you had, dear Yusra? 75 patients. Okay, we found many necrotizing myopathy and many patients previously undiagnosed, and we were successful to treat most of these patients. So this is thanks to you because you told us about this panel in France, and we succeeded to have a panel of 24 antibodies. Then we have a panel with 40 antibodies, and together with MRI, we also have the protocol of whole body MRI in the hospital, in Demirdesh and in Shams, and many radiology centers now all over Egypt started to have the whole body, not lower limb only, whole body MRI muscles. So we can diagnose inflammatory myopathy by MRI and by the panel. And also, this whole body MRI, as Professor Eduardo said, can give you the pattern of muscle affection. You can diagnose dystrophinopathies, Duchenne Becker, sarcoglycanopathies, collagen 6, and other disorders. So, thank you. Questions, because before we start the second, يلا questions. مايك بصوا بقى، هكلمكم بقى. احنا عايزين نتفاعل، عايزين نسأل عشان نتعلم. انا كل سنة بتعلم من الاساتذة اللي بيجوا، خدوها فرصة حتى نتناقش ونغلط، يا ريت نغلط عشان نتعلم.
I have two questions. The first one is about FSHD. Yes, what's the regimen for cardiac monitoring for the follow-ups? Do you do a baseline cardiac monitoring only, or cardiac echo and Holter monitoring or ECG, or you do it regularly on annual basis also?
So, in general, although there are studies that show that one third of patients develop cardiac involvement, what we do when we diagnose the patient, we do a screening with ECG and ultrasound. Okay, if there is something, we monitor with the cardiologist every 6 months. If there is nothing, I check every 2 years.
With the normal ECG, not a Holter or long-term monitoring.
ECG and ultrasound.
And ultrasound.
Because in general, they have a cardiomyopathy, not rhythm disorder, like, for example, Steiner patient.
The second question is about the facial muscle weakness in inflammatory myopathies. Is this common, or is this
The
facial muscle weakness?
facial muscle weakness.
Yes.
It's not very common. Okay. I had 2 cases of patient with autoimmune necrotizing myopathy. Okay. HMG-CR antibodies positive. They had some facial weakness, but in general, it's not common.
Okay, because we have a patient, a young patient, she's 9 years old. She was diagnosed with muscle biopsy as inflammatory myopathy. And when we did the antibodies, we found her positive for PL7, PL12 antibodies. But she has minimal facial weakness on eye closure. So I was thinking, should we revise her diagnosis or
Yeah, because PL7
not very specific?
not very
Not very
specific
specific.
in our
Yeah,
experience.
but she was very, she was initially diagnosed with the muscle biopsy and she responded on steroids. She
Yeah.
showed improvement on steroids.
So it could be, but the PL7 sometimes it's not
It's
easy
missing.
to determine if they are really pathogenic or not. Okay, and the CK go down with the steroids.
Mildly decreased, then it increased again to one. She's always around 1,000 or 900, so it's not very elevated. So I was thinking
Because usually when you have a good response, did you treat it with steroids and immunosuppressive drugs or
yeah, she
only
only received the steroids so far.
the steroids?
Just
You can try to do an immunosuppressive, so like methotrexate.
methotrexate,
And see. And the other things, if it's a necrotizing myopathy, based on the muscle biopsy, okay, you can, the best is to do IVIG, immunoglobulins. So we have seen that
for
necrotizing.
maintenance suppression, not only induction, for maintenance.
Globulin.
Okay.
Okay. So if the immunosuppression doesn't work, we take out and we leave steroids and IVIG.
Okay,
But the IVIG is the gold standard for especially early onset necrotizing myopathy. But it will be nice to see the slides of the muscle biopsy to see.
I think yes, we have, because I was rethinking when I saw the facial muscle weakness that since in facial scapular humor there's sometimes inflammatory
this
cells.
is this is the other possible diagnosis. But usually FSHD do not respond to steroids. Then when you see respond, the weakness, she completely retrieve her muscle, or she still
not
fully.
Mild improvement. She still has troubles in climbing stairs and
because you know
and
steroids
upper
can improve other patients. Now there are like a few studies that show that the low dosage steroids, for example, in calpainopathies, can ameliorate a little bit. So yeah, and we use, for example, steroids for congenital muscular dystrophy, Fukutin related. I have a patient that is treated with this and is doing better. The other things that you should think of is lamina C, Emery-Dreyfus. Sometimes, well, it's not, you can recognize because they have a contractures, they have cardiac involvement, but sometimes they have a muscle biopsy with inflammation and they respond to steroids. Okay. Is she having a head drop?
No.
No. Okay.
Thank you so much.